Hello, everyone. My name is Dr. Marianne Gausche-Hill. I'm the medical director of the Los Angeles County Emergency Medical Services Agency, professor of clinical emergency medicine and pediatrics at the David Geffen School of Medicine. I'm also clinical faculty at Harbor-UCLA Medical Center in the departments of emergency medicine and pediatrics, and senior consultant for the EMS for Children Innovation and Improvement Center. And today I'm here to talk to you about a topic that we've all had to face with the increase in behavioral health conditions that we're seeing, especially in children. And this is funded through HRSA HHS, and you see the award there. And I need to state that the contents are those of myself and do not necessarily represent the official view of nor endorsement of any of the federal agencies, including HRSA, HHS, or the US government. So thanks. Here we go. So we're going to start out with some of the resources that are out there. And this is a great algorithm that can be incredibly helpful, along with additional resources that are at the site. And we'll have a QR code at the end so you can click onto it. But this is by the EIIC and TREC, which is Translating Emergency Knowledge for Kids. As you can see, the algorithm starts out in recognition of agitation, some of the initial strategies like de-escalation and calming, and then it moves to what is your assessment, what do you think is going on, and potential pharmacologic interventions, if indeed those are necessary. So now we're going to dive into potential pharmacologic. And when you consider pharmacologic measures, you may really need to think about what you think is going on. And there's some particular buckets. So let's just go over some of those buckets, and then we'll kind of do a deeper dive. So developmental delay or autism disorder, these patients can be really tough because they have difficulty understanding context. And one of the things that I find is you don't want a lot of people in the room. You don't want a lot of people talking at once, only one person, and that you really listen to the caregivers who know what actually works for them at home. And again, if you're going to utilize medications, if at all, try oral medications if you can, if indeed you get that far. And sometimes just with either environmental, turning out the lights, making a calm environment, giving them something to eat or drink, keeping them warm, having them do what they normally do, they'll be fine. I'm going to run through the rest, and then again, we will do a deeper dive. So suspected psychiatric diagnosis, this has been very helpful to understand, and what worked before might work again, and was there a change in meds, and all of that goes into the equation. You need to look for an organic source, of course, and we'll talk more about that. And once you get to a point where you need pharmacologic intervention, there's a number of options based on how well the patient cooperates. Pain. If they have pain as a trigger, obviously treating that pain is going to be critical. Withdrawal or intoxication, it may be an unknown substance or it may be a known substance. So keep that into the equation. In regards, as an example, if it's alcohol, you don't want to add, and they're acutely intoxicated, you would not want to add a benzo. But if indeed alcohol is not involved, benzodiazepines can be very helpful. And finally, unknown etiology. You're obviously looking for an organic cause, trying to figure out the triggers, and then you just have to move along the algorithm to get to the point where, again, pharmacologic intervention is going to be needed. So the goals of pharmacologic intervention really is to calm the patient, to be able to rapidly evaluate and manage them. And it may be to do diagnostic studies as well. You also would like to be able to calm them enough that you can target the cause or the triggers, as I mentioned. So one of the questions you want to ask, this is one of the most serious things, is it delirium? So there's many terms for this. It's called excited delirium, agitated delirium, delirium with agitated features. And the patient often demonstrates some of the cardiovascular effects as well as confusion. So they'll have confusion, tachycardia, they may have tachypnea, they may have diaphoresis. All of these things we see, and patients with this delirium with agitated features can have cardiovascular collapse, including sudden death. So it is an important thing to evaluate appropriately and treat appropriately. So you want to make sure you address the vital signs and initiate a medical workup. And that medical workup is going to be individualized for your patient. And it may include many, many things, electrolytes. It could include ruling out rhabdomyolysis, EKGs, tox screens, CT of the head, chest x-rays, etc. You're going to initiate your workup again, individualized for your patient. Once you get to a point where you feel pharmacologic intervention, we typically do this fairly early on because of some of the cardiovascular effects, would be to utilize drugs that could, as an example, antipsychotics like quetiapine or Seroquel, risperidone. You can see olanzapine is a great drug. We often use haloperidol. And again, if you can avoid benzos, although we typically do use benzodiazepines in the field, so they may have already received that by the time they get to you. Okay, but we have other drugs available to us that may be more appropriate. And the antipsychotics are definitely the ones that are my go-to, either the atypical antipsychotics such as olanzapine or the more typical psychotics that you see like quetiapine or haloperidol. What if it's substance abuse or withdrawal? So I mentioned investigation, tox screen, they could have had a suicide attempt. So you always have to think about co-ingestions, say alcohol, Tylenol, alcohol, aspirin, etc. Are they on opiates? Do they have a withdrawal syndrome where you get a great deal of agitation? You can get kind of an akathisia as well. And so some of the things that we consider for these in the withdrawal phases are the benzodiazepines because they're anxiolytic. You may need to add an antipsychotic, as is shown here, haloperidol or chlorpromazine. What if the patient's autistic? I mentioned working with caregivers. I think this is critical. Previous medications that have worked, right? That is always helpful. And then are there environmental triggers that you can address right away? You know, pain, hunger, other physical needs such as warmth. And then try to modify some of the behaviors. So behavioral interventions that have worked, holding hands, putting the hands together, holding themselves. I've had kids do that. Sometimes they like to rock. Any of those things that help calm them is good, things that they've used at home. And again, there's a number of different meds that can be used, and you can give them PO. And olanzapine is a great one, as well as risperidone are the go-tos for me, but clonidine could also be used. And then does a patient have a psychiatric diagnosis? And there's any of a number of psychiatric diagnoses, and you may want to use medications that they've had at home. Benzos work really well for catatonia. If ADHD, you may want to restart them on their meds, and unless they are so agitated that you may need to move to a antipsychotic or give something intramuscular. But these are all potential scenarios for patients who've had previous psychiatric diagnoses. Well, what if it's unknown? And that's going to happen a lot until you can get some collateral history. So again, with the mild, you want to attempt verbal de-escalation, behavioral changes, environmental, and hopefully you don't have to give anything. If you do have to give something and it's mild and they still remain agitated, I really like PO, olanzapine, that works great. And sometimes benzodiazepines work really well in this particular instant. If they don't actually, show signs of something where you wouldn't want to overly sedate them. So moderate diphenhydramine works pretty well. Some kids get agitated on it too. It can have a paradoxical reaction, but I really find that almost all the kids that I see do not, and the diphenhydramine works great, especially if you're going to give an antipsychotic. I always give diphenhydramine to avoid a potential downstream dystonic reaction. Benzos can be great, olanzapine, as I said. And if they're more severe, you have to think about using the antipsychotics and giving either a PO or intramuscular. It just depends on the the cooperation of the patient. All right, this is a resource that EIIC and TREC put together, which I really like. It goes through and tells you the drug, the route, the dose, the onset for both IV, IM, PO as appropriate, as well as some other considerations. So they divide it into mild, moderate, and then into severe agitation. And so once you get to that stage where you're saying, is this moderate? I'm going to have to give them something for it that's generally in the moderate category, although it could be mild. It just might make them be able to tolerate the entire workup and evaluation a little bit better. And then severe, it may be when minutes count. And I often find that you have to have physical restraint along with pharmacologic interventions in order to be able to really get them calm and keep them from hurting themselves or others. Here's a QR code that's going to link you to the resources that you need, that EIIC algorithm, which I think is really helpful, and the medication table. I personally want to acknowledge Doctors Patrick Kelly and Eric Chung for their assistance with me as I developed this talk for you. And obviously the wonderful expertise of the EMS for Children Innovation Improvement Center and TREC for them really coming together to collaborate on these resources that will help you take better care of your patients. Thanks for listening. You can email me at mgausche-hill@dhs.lacounty.gov or on Twitter at mgausche-hill. Thanks so much.